It's another three-letter acronym. ARG, I think.
Now I don't know because I don't have the thing. I can logic it out based on. Yeah, I know.
Okay, shall we resume our discussion? Are there questions that have come up? Does anybody remember how to interpret a Lineweaver-Burke plot? I don't know if this is going to work as a clicker slide or not. Why don't you take a look at this question? And talk it over with your neighbor. It's a little complicated.
Which one is more active? So are we when we're talking activity, are we looking for a higher VMAX? And there's just like
And when there's less
So this is the Lineweaver-Burke. So the y-intercept is going to be 1 over v. So since k has a smaller one, actually it's bigger.
It's bigger, so it's faster.
Yeah, so it should be bigger a form because it has a higher Vmax and then x-intercept. So it encourages most of k.
And so then A is going to have a higher KM too?
Yeah.
Okay.
Oh no, it has a
well, that's the thing too, is like at what
Okay. Do we have a consensus on this one? Okay. So we've got the 1 over Vmax is red on the y-axis. And then the 1 over negative Km is red on the x-axis. So if we look at the A and the B form, which one is most active? And I'm, still a little cross-eyed here, so I'm going to... Okay, so the A... Yeah, maybe easier. So the A form has a higher Vmax, right? So it's got a lower 1 over Vmax, so that means it's got a higher Vmax, right? And it has a lower Km. Km is the substrate concentration, so it's more active at lower substrate concentrations because the 1 over negative Km is higher. Does that make sense? Now, this doesn't fit the neat definitions of competitive or non-competitive inhibitors, right? So we're looking at something different here. Yeah.
1 over negative Km is the x-intercept then?
Yes.
And it's, oh, because it's lower, that means that it...
Yeah, so...
Sorry, I'm very confused with the x-intercept aspect of it.
So like 1 over 0.4 is bigger than 1 over 0.1, I think is...
That's right.
Right?
Okay, yeah.
Okay, so that's how you have to... Yeah, you gotta use some old math.
My brain.
Okay, so what are the A and the B form? Well, the A form is more active, and the B form is less active. And, in the early days of study of glycogen metabolism, that's kind of what they knew about it. And the difference between the two forms is a reversible phosphorylation. So the glycogen phosphorylase is regulated by phosphorylation, and when it's phosphorylated, it's active. Now, this is completely opposite of glycogen synthase. When glycogen synthase is phosphorylated, it's inactive. Okay, so keep those two things in your mind, and we're going to discuss in gory detail about how you get to that phosphorylation status. But I think if you just kind of keep, those facts, the active glycogen phosphorylase is phosphorylated, and the active glycogen synthase is unphosphorylated. Like, remember those, then you can kind of work backwards up the pathway. Okay, so let's consider and I think I just mentioned this. So I'm going to use kind of the same cartoon for the next few slides to talk about this. Okay, so what we want to do in all of our tissues is to coordinate the regulation of glycogen synthesis with the regulation of glycogen breakdown. Right? Now that means you have to turn different enzymes on and different enzymes off. Right? So the way that we do that is through this regulation by reversible phosphorylation. So in the fasted condition, in fasted metabolism, what does the body want? Like what if you're fasting, where do you want glycogen synthase and glycogen phosphorylase to be?
You're fasting?
Yes.
And then you want glycogen to be turned on, so then you'd be the phosphorylase, correct?
Yeah. So in the fasted condition, you would want the phosphorylase to be active and making glucose 1-phosphate, and then you don't want that glucose 1-phosphate to be used to make new UDP glucose and more glycogen, so you want to turn glycogen synthase off. Okay, so does everybody get kind of conceptually of, like, give the cell a motivation and see what it wants there? Okay, so how do we get there? Well, we know that the main endocrine signal that's regulating fasted state metabolism is glucagon. Epinephrine is kind of along with glucagon as a fasted state hormone. Skeletal muscle cells don't have glucagon receptors, but they do have epinephrine receptors. Okay, so there's kind of a little wrinkle there. Okay, so with the glucagon receptor, that's a G protein coupled receptor that's linked to adenylate cyclase activation. And when you get adenylate cyclase activated, you generate cyclic AMP, and the cyclic AMP then acts as a second regulator that activates protein kinase A. So protein kinase A has multiple subunits within the cell. So protein kinase A is directly phosphorylating the glycogen synthase enzyme, and that contributes to its inactivation. Okay. The protein kinase A is also phosphorylating glycogen phosphorylase kinase. Glycogen phosphorylase kinase phosphorylates glycogen phosphorylase and activates it. Glycogen phosphorylase kinase also, to make the things more confusing, it's also acting to phosphorylate glycogen synthase and inactivate it. Okay. So that's kind of how we can get from glucagon and then the beta epinephrine receptor through protein kinase A activation to hold the glycogen synthase in the inactive state. We also have glycogen synthase kinase, and this is a substrate for phosphorylation by protein kinase B, which I'll get to in a moment. And in the absence of that phosphorylation, the glycogen synthase kinase is active, and there is a glycogen synthase kinase inhibitory phosphorylation site on glycogen synthase as well. Okay, so glucagon signaling is here. And then I think that's shown here as well. So let's talk about that. And okay, so this is showing that same adenylate cyclase protein kinase A pathway, and this is also showing the regulation of synthesis and degradation. So let me move on to beyond the glucagon receptor. Okay, so the alpha adrenergic receptor, this is coupled to a different signaling pathway, and I think that Dr. Holy has discussed this one. So this is using a lipase enzyme that's cleaving the inositol head group from phosphatidylinositol to make two products, diacylglycerol and then inositol trisphosphate. Did I get it right? Okay. Okay, so the inositol trisphosphate, this acts at mobilizing calcium pulses from endoplasmic reticulum into the cytoplasm, and then kind of similarly to the insulin release, right, in a beta cell, that calcium then can activate calmodulin kinases, and those calmodulin kinases have a substrate for phosphorylation on the glycogen synthase. Diacylglycerol, this acts as a second messenger that activates protein kinase C, and protein kinase C again has a phosphorylation site on glycogen synthase. Okay, so you've got these multiple phosphorylation sites that can be all coordinately phosphorylated by kind of the same signals within the cell. Okay, so that's summarizing the fasted state signaling, and this is specific for a hepatocyte. There's a little bit of a different wrinkle in a muscle cell. And so I think this is, again, just the Marx version of the cartoon I had earlier, so I'll leave this for the moment. Okay, so with a muscle cell, we don't have the glucagon receptor. There are insulin receptors in muscle cells, of course, but we don't have the glucagon receptor. So just kind of generally in a muscle cell, the glycogen metabolism is going to be less endocrine sensitive and more sensitive to intracellular energy demands. And there's kind of two things that are going on with that. I mean, first of all, epinephrine, that's going to be associated with muscles doing work. That's going to be the signal of work being done. And that's going to lead through the beta adrenergic receptor through the protein kinase A pathway. We also have, when a muscle is doing work, there are transient pulses of calcium that are entering into the cytoplasm, and that's, mediating the myosin contraction and the actual work that's being done. And then as a second effect of that calcium, you're getting the calcium calmodulin kinases that are active, and that's going to provide the energy and the ATP ultimately for that work that's being done. A third input is the AMP kinase pathway. AMP kinase, or adenosine monophosphate kinase, this is acting as an intracellular kinase that is regulated or activated in conditions where the ATP to AMP ratio is low. So if you're doing a lot of work, you're hydrolyzing a lot of ATP, the adenosine diphosphate kinase reaction will be making a lot of AMP, and then that's going to activate AMP kinase. AMP kinase has a lot of different substrates in the cell and affects protein synthesis and diverse other products. But one of the things that it's going to be doing is phosphorylating and activating the phosphorylase kinase enzyme, and phosphorylase kinase, that's going to inactivate glycogen synthase and activates glycogen phosphorylase. That then will provide glucose, and if this is a muscle cell, this should be glucose 1-phosphate and glucose 6-phosphate, right? Everybody with me there? Okay, so anyways, that glucose 6-phosphate then, that can be a glycolytic substrate and be used to generate ATP, which will ameliorate this imbalance between ATP and AMP. Is that all good? Okay, so this is kind of my cartoon version of that, and then the Marx textbook cartoon version, I think, is shown here. Okay, so let's consider regulation of glycogen metabolism in the fed state next. Now, when the biochemists were initially describing the enzymes on glycogen metabolism, they didn't really know, active or inactive, or phosphorylated versus unphosphorylated. So they gave them these A and B names, and then with the glycogen synthase, there's also the I or the D. So you may see that terminology. I'm going to refer to, active glycogen synthase, active glycogen phosphorylase, and phosphorylated or unphosphorylated. Okay, so you have to know that, but at some points in your careers as medical students and physicians, you may hear this other A or B nomenclature, but by that time, it's no harm if you just look it up, right? Okay. Okay, so similarly with the glycogen phosphorylase, glycogen synthase is regulated by the reversible phosphorylation. And let's see if we can remember all of the kinases that can phosphorylate glycogen synthase. And I'm not sure if you can select multiple answers. Does it let you select multiple answers? Okay, let's just go down the list. Succinate thiokinase. What's that doing there? Nope. Protein kinase C. That's a yes. Protein kinase B. When is protein kinase B active? With insulin signaling. So that's a no. Protein kinase A. That's a yes. Calcium calmodulin kinase? Yes. Glycogen phosphorylase kinase? That's a yes. Glycogen synthase kinase? It's right in the name. That should be a yes, shouldn't it? Yeah, yes. Pyruvate kinase? Pyruvate kinase, that's a no. Pyruvate kinase, that's a metabolic enzyme in glycolysis. Right? B cell tyrosine kinase, that's involved in B cell activation. Okay, so the point is that there's diverse inputs into the glycogen synthase phosphorylation. Okay, you should recognize protein kinase B as being associated with insulin receptor signaling, and insulin receptor signaling is associated with fed state metabolism. Okay, now protein kinase B, the substrates for protein kinase B, again, are diverse within the cell, but with respect to the glycogen metabolism, there's one kind of direct effect, and that's on phosphorylating and inactivating the glycogen synthase kinase. Okay, so that's inactive, then you don't have the inhibitory phosphorylation on glycogen synthase. Another substrate of protein kinase B, and one of the major mediators of insulin's intracellular effects, is the phosphorylation and activation of protein phosphatase 1. So protein kinase B, we refer to that as a promiscuous kinase. It has more than one substrate. Protein phosphatase 1 is a promiscuous phosphatase. So it's removing phosphorylations from multiple different sites on different substrates. Okay, and protein phosphatase 1, that's really erasing what has been done by protein kinase A, calcium calmodulin kinases, and all the other kinases. Okay, so protein phosphatase 1, that's erasing the inhibitory phosphorylations on glycogen synthase, and it's erasing the activating phosphorylations on glycogen phosphorylase. Okay, so the signaling in the fed state is maybe a little conceptually simpler. Is that all good? Can we leave that? Okay. All right, let's look at a question. And go ahead and refer to your notes, or talk it out, but This is, I think, this would be a pretty challenging question, but I think it's something like this would be fair game. And one approach to this question is, what is a cell stimulated with insulin want? Does it want synthesis or does it want degradation of glycogen? Okay, what have we come up with? Okay, glycogen synthase is unphosphorylated and active. Pretty straightforward. Okay, so I'm not gonna try to kill you with questions like these, and I know the nomenclature is kind of confusing whether you're going one to the other, but it's fair game. So give it some study. Okay. So what about kind of a higher level question here? And if anyone has color blindness, I apologize. But okay, so why don't you take a moment and discuss with your neighbor this question, and I'm going to ask for how many different reasons you can come up with for why one cell is one thing and the other cell is the other thing.
Yeah, that's a good one. The other one has oh, actually, it gets converted.
Okay, do we have we ready for this? So let's see. Okay, super. Is that 100?
Yes.
Awesome, great. Well done. Okay, so what's one reason why the blue cell is a muscle cell and the purple cell is a liver cell? What's that?
Muscle cell is only affected by epinephrine, whereas liver would be glucagon and epinephrine.
Super, awesome. What's another one? Yep, awesome. So glucokinase, this is the high Km version of the hexokinase enzyme. Good. Yeah. What was it?
It was the transporters.
The transporters. So this is the low affinity transporter, GLUT2, and this is the high affinity transporter. Good. Yeah. Yep. Yep. And that's reflecting that important role of the liver in making glucose available out to the blood. Yeah. What else?
The AMP and calcium, those are going to be like a result of muscle cells working, and then those will feed into the muscle cell pathway.
Yep, very good. So here, is there anything else? I guess just the general relationship of one cell providing glucose for another. Yeah. So what metabolic state is this person in?
Fasted.
More consistent with fasted metabolism, right? Yeah, good. Are there what questions do you have up till now? Okay, well, let's conclude with a discussion of glycogen storage diseases. Glycogen storage diseases, these are disorders in carbohydrate metabolism that result from loss of function mutations that are inherited from parents. As I mentioned earlier, they can be kind of conceptually divided into two classes, those that affect the liver and those that affect the muscle. So the liver effect, the main effect is going to be fasting hypoglycemia. Okay, so the liver has an inability to sustain blood glucose concentrations in the fasted state because it can't metabolize glycogen appropriately. Okay, in the muscle, the mild forms can manifest as exercise intolerance or pain during exertion. And then if it's more severe, that can be manifest as heart failure if it's affecting the heart muscle and if it's, very severe. Okay, so let's look at where some of the glycogen storage diseases are, and yeah, I have a hard time reminding myself where they are. Okay, so glycogen storage disease 0 is the glycogen synthase deficiency. Glycogen storage disease 1, this is glucose 6-phosphatase deficiency. So glycogen storage disease 1, is this going to affect liver or muscle? Liver, right, good. Okay, so because there's only glucose 6-phosphatase in the liver. Then the phosphorylase deficiency is glycogen storage disease 5, and this can be either a muscle specific or a liver specific. Okay, so let's look at these one by one. So the glycogen storage disease 0 is the glycogen synthase deficiency. And this is, I have listed here as rare. These are all pretty rare conditions, although not unheard of here in Minnesota for sure. So there are two genes, as I think I mentioned earlier, two glycogen synthase genes, the liver-specific one and the muscle-specific one. And the liver-specific one, this is distinct from all of the other liver-specific ones in that it has a smaller or abnormally small liver, whereas the other glycogen storage diseases that affect liver tend to be associated with hepatomegaly or an enlarged liver. The glycogen storage disease 0, this also has kind of an unusual feature of an exaggerated postprandial glycemic response. And I'll touch on that in a little bit here. So the treatment for the glycogen storage disease and the GSD0, and this is really the liver version of it. The main problem is hypoglycemia in the fasted state. So for this condition, you want to avoid fasted state metabolism. Okay, so you have the person have very frequent meals, frequent small meals that contain carbohydrates, so that's the blood is always being replenished with glucose from dietary carbohydrates. There's also frequently, have you heard of a glycemic index? Okay, glycemic index is like how rapidly glucose is released from a carbohydrate food. And if you have foods that have a high glycemic index, like uncooked cornstarch is one of them, like before bed, if you give the child uncooked cornstarch, then you get this kind of slow release of dietary carbohydrates over time, and you can hopefully avoid the fasted metabolism. And that's, I think I've got that for other conditions as well, but really that's the main treatment for any of the glycogen storage diseases that would manifest as fasting hypoglycemia. Okay, so GSD1 is von Gierke disease. This is a deficiency in glucose 6-phosphatase. So glucose 6-phosphatase, there's no problem with making glycogen. Right, so in the fed state, a person with a glucose 6-phosphatase deficiency can pack on the glycogen with no problem, but in the fasted state, then when the person needs energy from that stored glycogen, there's no way to get it out of the liver, right? So you get and this inability to get the glucose 6-phosphate dephosphorylated to glucose, that's going to back up all the way and, result in an accumulation of glycogen. Now, glucose 6-phosphatase deficiency, it's referred to as a glycogen storage disease, but it's important to note that gluconeogenesis, or the generation of glucose using amino acids or lactate or glycerol or things that come outside of the liver, gluconeogenesis also generates glucose 6-phosphate, and that has to go through the same enzyme if it's going to be exported out into the blood. Okay, so the fasting hypoglycemia in von Gerke can be more severe because you have fewer options to sustain the blood glucose. So yeah, the condition is, the hallmark is the fasting hypoglycemia. This lactic acidosis, this can occur because you've got too much carbohydrate trapped in the liver, and the liver tries to get rid of it through glycolysis and making lactate. This would be a ketotic hypoglycemia because there would be, a normal ketone body response. The hyperuricemia, this is referring to increased uric acid, and we'll talk about this towards the end of foundations, but this is a result of nucleotide catabolism, or breaking down nucleotides to try to, sustain energy. And then the hyperlipidemia as a compensation for the lack of carbohydrate energy, the increase in free fatty acids in the blood is can occur. The treatment, again, avoiding the fasted state metabolism. So you have frequent meals, and you can, live a largely normal life if you have careful attention to your diet. Now, these are very rare conditions. Has anybody heard of a zebra in medicine? Or what's a zebra?
Your hooves, you think of a zebra rather than like more common a horse or something like that.
Yeah, and I think you're encouraged to not look for zebra because horses are a lot more common. Yeah. Am I getting that right? Okay, so there was a article in the Star Tribune a few years ago, almost 10 years ago. This was written by a woman. She actually works for the university down in the Minneapolis, but she wrote about her experience with raising a son with von Gerke, and the very difficult arriving at the diagnosis, and kind of challenging to have a kid like this age to be having that close attention to their diets, because kids tend to not eat what you want them to eat. Anyway, I think this is a quick read, and hopefully that link will still work. But I think it's just something to ponder. Generally we are looking for things that are a lot more frequent, but these things are here in Minnesota, and you certainly don't want to miss them. Okay. So anyway, just for your review, and yeah, I last communicated with the author of this a couple of years ago, and Bodie is doing fine now. So he's got to be in his late teens by now. So okay, so let's move on to another glycogen storage disease. This is a failure of that 1,6-glucosidase activity in debranching enzyme. So glycogen storage disease 3, or Cori disease, this is hepatomegaly, or an enlarged liver can result because there's no problem with glycogen synthesis in the fed state. You can pack on as much glycogen as you want. However, the glycogen phosphorylase in the fasted state, when that's trying to release glucose 1-phosphate, every time it gets to this stump that's remaining because the 1,6-glucosidase activity is absent, then the phosphorylase is going to stall. Okay, so in somebody with a debranching enzyme deficiency, the products of glycogen metabolism, the products of glycogen breakdown are only going to be a little bit of glucose 1-phosphate, and you're never going to get the free glucose from removing the stump here. Okay. There are two forms. The A form is more severe and affects liver and muscle. The B form is liver only, and that tends to, if it's recognized and if the nutrition is carefully managed, that can largely correct itself as in adulthood. And that's shown, illustrated here again from that figure from the Nelson textbook of pediatrics. This is a kid with the Corey disease type 3B with the liver specific only, and you can see this profound hepatomegaly reflecting the massive accumulation of glycogen and no way to get rid of it. And then this is the same guy as an adult, and he's largely normal in terms of the hepatomegaly and in terms of the tolerance of fasted metabolism. Okay, so glycogen storage disease 3, this is not one of the bad ones. Glycogen storage disease 4, this one, and the rationale for why this is not so clear to me, but this one is much more severe, likely to be fatal in infancy. This is the deficiency of that 4,6 transferase activity in branching enzyme. So you would think you would have an issue with hepatomegaly, or you wouldn't have an issue with hepatomegaly because this is a disorder in glycogen synthesis. But you are packing on a lot of glycogen, and it's in, well, it would be in the really long, wavy form that is difficult for phosphorylase to get at. Okay, so you have the fasting hypoglycemia and hepatomegaly, failure to thrive, and again, this one is, for reasons that aren't clear to me, this one is much more likely to be fatal. Okay, then the final one, that is, again, this is compared to the glycogen storage disease 4, the branching enzyme deficiency, the McArdle disease or glycogen storage disease 5. This has a more mild phenotype, if you will, of exercise intolerance. So this is a deficiency in the muscle-specific isoform of glycogen phosphorylase, and the problems of pain during exercise, this is because of energy starvation of the tissue because they can't rely on that glycogen. If you remember, do you remember anaplerotic pathways a long time ago, right? Remember the myoadenylate kinase reaction? Right, so in people with the muscle-specific glycogen phosphorylase reaction, they're going to try to compensate for that energy starvation by increasing that AMP-dependent pathway. Okay, so one way you could distinguish the hallmark feature of exercise intolerance, you could distinguish the McArdle disease from an AMP deaminase deficiency would be looking at that ammonia level in the blood after exercise stress test. Now that's something that you may observe in an academic setting. It's not really a diagnostic test necessarily. So McArdle disease, the GSD5, this has a pretty good prognosis, and if you work at it, you can build exercise intolerance despite having this deficiency. Okay, are there questions? Okay. I'd just like to note this diagnostic key, and I don't know, a month or so ago, this may have been pretty daunting to look at something like this, but I'd ask that you just take a close look at it and consider like our hyperinsulin case from Monday, right? And that is shown here. So fasting hypoglycemia, right? And our patient was, profoundly hypoglycemic with the insulin. insulinoma. She didn't have an acidosis, right? Because there's no substrates, there's no ketone body response because her body thinks that it's in the fed state because of the hyperinsulin, right? There's not going to be any free fatty acids because her body is not, it thinks it's in the fed state. It's not going to be activating hormone-sensitive lipase, okay? So that kind of goes down this way. And just consider medium-chain acyl-CoA dehydrogenase deficiency. That's a fatty acid oxidation disorder that can also manifest or have its initial presentation as fasting hypoglycemia. In that case, you're going to have high free fatty acids because it's not an endocrine problem, right? You don't have a disordered insulin or glucagon problem. Your body is starving and it knows it's starving, so the endocrine response is appropriate. The problem is that you make free fatty acids, but you can't convert them into ketone bodies because you can't go through beta oxidation. Okay, so anyways, I don't want to go through all of these, but I just kind of walk through a few of them because I think they can kind of make sense, and I'd want to give you some confidence in looking at this. And there's a lot here that we haven't talked about, and you're not, certainly responsible to it, but if this is useful to you, well, you got it now. Okay, should we look at a couple of cases in our last few minutes? Okay, so let's look at our first case with the chief complaints of short stature in pediatric endocrinology. What are your impressions?
He's making ketones right now.
Yeah, so she's got hypoglycemia, and she's got a ketone body response, which is appropriate, and suggests that she doesn't have a problem with fatty acids metabolism. Does she have an insulinoma? She's got below normal insulin, and that's appropriate giving her profound hypoglycemia, right? Growth hormone, I think this is something they were looking at because this is a pediatric endocrinology clinic and she has a chief complaint of short stature, so they're trying to look at that as a cause. And that's normal, so I don't think that this is a growth hormone deficiency. The cortisol is up, and I think this is just, because she's severely stressed, and cortisol would provide other substrates for her body. Okay, well, what would you do with this patient at this point? Okay, so in the interest of time, I'm just going to run through this. The patient had an oral glucose tolerance test, and this is a test where the patient is instructed to fast overnight and then come into the clinic, get their blood glucose tested, then drink a high glucose drink, and then have their blood glucose tested at intervals afterwards. Okay? Now, normally, a patient in the fasted condition is going to have, glucose concentrations between like 80 and 100 milligrams per deciliter. And the processes that sustain that glucose are glycogenolysis and gluconeogenesis in the fasted state. Okay? Then you drink the glucose drink and your glucose level should increase because the digestion enzymes are bringing that glucose into the blood. If you have an appropriate insulin response, then your glucose concentrations will drop back into the normal range, right? Does that make sense? Okay, so that is a normal response. The asterisks here are showing our patient's response. So what about just in the fasted state before she drinks the glucose? What would you call that?
Hypoglycemia.
Okay, so she's got hypoglycemia. Then what about after that glucose drink? Hyperglycemia? Yep, exactly. It goes down though, so she's making insulin, like her insulin response seems to be appropriate, but she's got a fasting hypoglycemia and then an exaggerated glycemic response after eating. Any thoughts on this one?
Like a glycogen storage disorder, like it's using glycogen at inappropriate times, so it runs out, and then, but it's.
So why would she have this? Do you have a thought?
Maybe have a problem with glycogen. There's not any.
All right, very good. There's somebody left one chocolate up here for you. So, right. So that's a excellent observation, and that's precisely the cause of this case. So the glycogen synthase disorder. So this would be GSD0. So she's got the fasting hypoglycemia because she doesn't have any glycogen, right, in her liver. She's got that exaggerated glycemic response after eating because one of the main metabolic fates for glycogen for glucose is absent. Okay, so this glucose up here, in a normal person, a lot of this glucose is being converted into glycogen. But our patient can't do that, so that glucose is going to remain in the blood longer. Is that clear? Okay. Okay. So this, so she not only had the hypoglycemia resolved through a pretty simple dietary intervention, but she also had that short stature resolved or was growing at a much more normal rate. Okay, that's shown here. I'm going to go through the next case in just I don't know if we've got time to do this or not. Okay, why don't we, okay. This is a case, let's look at this question. So this was a case where a kid who was previously healthy was running upstairs and then collapsed and died. Okay, and mitochondria from skeletal muscle, and I think this is heart muscle down here. The mitochondria, well, that's an abnormal looking mitochondria, right? The skeletal muscle or the muscle fibers are all disordered because of the glycogen deposits and abnormal mitochondria. Okay, so the diagnosis here, this is looking at skin fibroblasts, okay, that were taken from the child shortly after he died, grown in vitro, grown in plastic, and then they were looking for the rate of lactate release into the solution. So okay, you've got a dish of cells, you're growing in a media that contains glucose. Then you wash away the glucose-containing media and add a carbon-free salt solution. And then you're looking at the rate of lactate production in that salt solution over time. Okay, and these white bars here, this is a normal patient. And you can see the lactate concentration is going up. So if there's no glucose in the media, where is that lactate coming from? It's coming from intracellular glycogen that's being broken down and using for fermentation by those cells, right? So those were normal fibroblasts. The fibroblasts that were, isolated from the child shortly after he died, they did not have that response. So there was presumably a inability to get the glycogen, excuse me, there was an inability to utilize intracellular glycogen. Okay, so in this case, the problem was the muscle-specific isoform of glycogen synthase, And this is just showing the and yeah, I'm sorry, so we're over time, I'm not gonna go through this, but this was a loss of the glycogen, the muscle-specific glycogen synthase gene, resulting in sudden death. Okay, I apologize for kind of going through that quickly, but basically a couple examples of the same gene in the liver compartment and the muscle compartment having some pretty drastically different effects on patients. Okay. There's one other clinical case that I'll add into your clicker slide download shortly here.
Thank you.
Do you feel good? I do not feel good. I'm gonna have to get upstairs and fly for the next 2 hours. But I don't think it's gonna work.
Do you know where like Oxford is?
Like you wouldn't have like have so much fun.
Pathways or wherever care games are. There's gonna be one question.
I'll kick him like, what are you doing?
Joseph, come on in. I have a question for you.
No questions.
Go home? Good nap?
Okay, I'm trying to get to do it. I did not get through all of
What?
the dim lights in here.
All right, in the first clinical case, how can you rule out disease 3?
We'll see.
Rule out.
You don't know either. Got it. In the first case, I don't know how he ruled out 3 over 0.
And you guys could all, well.
On the questions on the quiz, I could actually like.
I think it'll
answer without.
Well,
You psyched?
Yeah.
well, I was Jim.
You probably
So
took
this is
way
the
more
first
laps
one.
than you had to.
And this was,
Chill.
no, you weren't chill. You were letting it work.